found the first session to be exceptionally informative about why this area really is so exciting. But I'm going to find this panel, I think, to be perhaps the most important panel of the day because the way the healthcare universe has really begun to dominate our thinking in this country. There's a great consensus in that healthcare costs are soaring. There's a great consensus around the fact that we can do a better job in providing healthcare services to our people. There is a fractured consensus at best about how we best do that. And there is a perceived need for innovation in a world where big pharma is becoming huge pharma, where the consolidation in all aspects of the business side of healthcare is quite daunting. And it makes one wonder whether innovation through technology or through better business processes really will be adopted, or whether it creates a new environment of opportunity. And we have a distinguished panel with a very, very varied but successful background here to talk about this. Our moderator is Dr. Robert Corona, who has a distinguished healthcare career that you can read about, followed by Eric Allen, who you heard speak so well before about this region and the possibility of the region. And again, our esteemed host here. David Klein, who is out of the insurance and healthcare management business, formerly having been the CEO of Excelis. We have Michael Totterman, who is a CEO of one of the companies in which in which ASV is invested in, Clario, and a successful entrepreneurial career at iCardiac. And then Lynn O'Connor-Voss, who is the president of Gray Healthcare, probably the best healthcare communications company in the world, which has fostered innovation among its clients and how it has delivered healthcare messages. It should be a fascinating panel, and with that, I turn it over to Dr. Corona, who will moderate it.
Thank you, Steve. Good afternoon, everyone. Listen, before we start, if you want any hair care tips, Mike and I will be giving them afterward. So we're going to start out today talking a little bit about innovation and what that does to the cost of care. So when you drive a lot of high technology into a system, I'm curious to hear what our panel thinks. Does it decrease the cost, and is that important? Or does it eventually increase the cost? And so who wants to start?
So,
You know a little bit about cost of...
staying within cost, guy.
So when I was at Excelis, I used to have something called the sales prevention department. Okay. And it was the actuarial and underwriting area. And they were very good at saying no, or setting a rate so high that nobody would buy. And in some ways, that's the character of the insurance industry, whether it's government-run insurance like Medicare and Medicaid, or private insurance. They do that for two reasons. I mean, their DNA is all about saying no. My CFO, by the way, his nickname was Dr. No. So to institutionalize the concept, we went that far. The insurance industry takes that position because everybody else does, number one. It's sort of cultural. And if they didn't, they'd have higher prices, and they wouldn't sell any insurance. And number two, and really the more important reason, because the public, whether it's taxpayers or whether it's employers or whether it's individuals that are paying the premium, hold the insurance industry accountable for being stewards of their dollar. And they want to make sure that whatever service is being provided, whatever device is being manufactured, is adding value. Value today is not just defined by a better outcome of care. That's not enough. Value today has to have an additional dimension of being no more costly, if not less costly. And you're wasting your time if you think that just because it's a better outcome of care by itself, that your go-to-market strategy will work. If you want to think about an example, the one that I like to go to sort of on a contemporary basis are these hepatitis C drugs, which cost in excess of $100,000 for an episode of treatment. And you're seeing all sorts of gaming taking place to avoid payment of these, even though these drugs cure hepatitis C. And they work very, very well if taken for 8 weeks or 12 weeks, whatever the protocol is, for the right patients to get rid of the hepatitis C. But the insurance companies do not want to cover those drugs unless it's pre-certified, unless there's going to be a highly adherent and compliant patient, and unless they can sort of foresee an offset in what their expense would be in downstream avoiding the cost of a liver transplant or something similar. So does it inhibit technology development? Yes. Is it important? Yes.
So it's interesting. I just came back this morning from a retreat with our medical school dean, and he asked all the chairs to figure out how are we going to spread the pot around and get more research to bring more innovation in with the same amount of dollars. So I would concur with you that we can't drive the cost up. But it's also hard for I'm a pathologist, so I don't have a lot of patient-facing time. But my clinical colleagues were saying, how do I tell? So I'm a brain pathologist, so my neurosurgery colleague said, how do I tell somebody that they can't go ahead and have this new therapy that Duke has, for instance, where they inject a polio virus into the brain tumor and the virus kills it, right? So they want the best care, and really cost is not an issue to them. So they look at the physician who seems to be caught in the middle of trying to create a scenario where they get the highest quality of care, but also have to be good stewards of the dollar. So, is there a model? Oh, you guys got an idea? Okay.
I don't know if it's the answer, but it's like, each of us can do the little piece that we can. So I often, as an entrepreneur, I take the entrepreneurial perspective. And I think David's absolutely right, is while in healthcare, and the reason most of us, almost all of us are in healthcare because we want to deliver something better. But it's also incumbent on us to make sure that we have a very good understanding of the constraints of the system. And one of those constraints is it cannot and should not be more expensive. So if you're just trying to kind of, come on the market and say, okay, this is going to cure X, Y, Z, and it costs a ton of money, that's not the best position to be in because we can't have infinitely expensive healthcare. So as an entrepreneur, the things that get me the most excited is when there's either an existing payment code or there is something that the physician or the healthcare system is willing to pay for because it makes the delivery of care both better and cheaper. And I think from an entrepreneur perspective, those are the places where you can get a lot of traction in the system. But I think David's point is really good, and it's a horrible thing to say, just because you saved a life, nobody cares. And I like saying that because that's not really true, but it gets to the point of like, yes, you do need to save a life in the context of delivering healthcare, but you also need to do it in an economically responsible fashion because financial resources are not infinite.
So I would just say that, a lot of attention always goes to the Hep C drugs and these enormously expensive procedures. But the bigger problems out there are care coordination, the lack of the IT systems that have never been built to really have interoperability. Care coordination is billions and billions of dollars, and we haven't tackled that yet. And then if you look at a condition like diabetes, where 9.3% of the population just in the United States have diabetes, we have consumers who are not following directions. We have consumers who are not very knowledgeable about their care. And the innovation where we can actually communicate better with patients and connect providers and patients with some technology that will, in fact, get them to a better place from a health perspective, that's going to save a lot of money. And some of the things we talk about, and again, I don't know when you say we can't be looking at outcomes alone, but we kind of think in terms of the bumper sticker for the providers, no outcome, no income. So with the incentives now driving providers to deliver better outcomes, we see at least some of our clients addressing that and meaningful use in a way with applications that hopefully will save money but also deliver better care. So, I think there's a lot of work essentially to be done with the masses before we just talk about these isolated cases in oncology and brain
I
cancer.
agree. The one thing I'd add would be primary care and screening.
Right.
To the list you just had. I mean, healthcare economics in this country are insane. We spend 17% of our GNP on healthcare. And so you have to look at numbers, and I actually don't think you start with the super specialized. I think there's too much time and energy at these super specialized, very, very expensive, whether it's a $100,000 Hep C or the fact that there are more MRIs in this country than in the rest of the world altogether. What really is needed is great care coordination and great primary care, great screening and management of the mass population, and then being able to deal with secondary and tertiary care. It's when the diabetics don't know that they need to control blood sugar, don't know how to do it, that's not happening, and they don't know the secondary diseases that will come from it. They don't know about retinopathies, and they don't go to see the ophthalmologist. I mean, every diabetic is supposed to go see an ophthalmologist once a year to have a dilated exam. And why is that? Because they'll get something called retinopathy. And retinopathy can be prevented. If you can identify it early enough, it can be prevented. Every diabetic is supposed to see that. Only about 20% do. And this leads to terrible outcomes. And I honestly believe that the solution to that isn't necessarily more specialization, but it's more management of chronic diseases, more primary care, more screening. And then that ought to save so much money on the rest of the system so that we can spend some of the kind of cool, fun money on some of these super specialized, whether they're drugs or...
The system is built for acute episodic
They
care.
are.
It's not built for chronic care. And I think until that changes, it's going to be very hard also, I think, from the insurance perspective to endorse the kind of treatment that is needed because of the way incentives are arranged right now.
I don't disagree with anything that has been said in terms of the importance of primary care, the importance of screening, the importance of better compliance and adherence. I think all of that is right on the mark. If you look at the cost curves, you find, though, a very small percentage of the population, usually 4 or 5%, accounting for 40, 50, 60% of the cost. Okay? And if you think about opportunities for intervention, it's usually those patients that have a handful of comorbidities, are often close to end of life, that consume a gigantic amount of money. That's what's tormenting Medicare more than anything else. If you look at the most expensive Medicaid patients or the dually eligible Medicare, Medicaid patients, those are the ones that they are, in terms of compliance and adherence, they have the hardest time dealing with, and that's in some ways low-hanging fruit. I mean, if
Dual eligible is $350 billion, I
Right,
believe.
and if
you
you
could coordinate that care a little better, we
right,
save
and
a
if you
bunch
and
of
if we
money.
can,
So let
if
me
you get
add-
your arms around that, then you begin to take down the cost curve. And that's not changing outcomes of care. That's not saying people should be put on icebergs and allowed to float away. That's simply using standard of care in dealing with these patients.
So let me ask you, if the consumer feels, let's assume there's more of a free market healthcare system, if the consumer felt they were getting value, what's the downside of going to 20% of the GMP? If you're willing to pay for the best of care, if an innovator's thinking about, well, who would have thought 10 years ago that we'd be spending $250 a month on a mobile phone or internet access, right? So if there's value, what kind of innovations have to come into play to allow us to have that GNP percentage climb?
I think that the downside for companies that compete globally is if we're paying 20% as a country for healthcare and China's at 3%, that's a big cost differentiation. So
I actually think the likelihood is that we're going to spend, as a percentage of GDP, even with an expansionary GDP, that we're going to spend more. And I think, like any other product that's out there, you're going to see segmentation, and you're going to see chunks of the population willing to spend more, willing to buy a private room, willing to buy concierge care, willing to sign up for full body CT scans, whatever it is, where they're, the insurance company is not going to cover it, or the government's not going to cover it, but somebody has that preference, that the utility function goes in that direction, and I think that's okay. But if you're talking about something that's socialized, whether it's funded publicly or funded privately, okay, then you're imputing some quality of life, some cost associated with quality of life, and that's going to to set some type of pattern. In the UK, British National Health Service, won't spend more than $50,000 a year keeping somebody alive. That have, the Hep C drugs there, either they're not going to be delivered, or the price is going to be reduced to $50,000.
Good. And I think it's a mental model question, because the question was really good, which is, if you're spending your own money for particular things, should you be, allowed to make that decision? And there are segments of the kind of the broader healthcare market where it's entirely pay out of pocket. A lot of, the company that we're right now doing, vision care, LASIK surgery, that's entirely out of pocket. So there are significant segments of the market where you don't necessarily run into, these components. So as an entrepreneur, those become very, very, very interesting.
Dental is another one.
Dental's another big one.
Wide open.
Cosmetic is another.
Yeah.
another big
And
one.
as you're seeing, as the labor market stays soft, notwithstanding, what's being told to us out of Washington with lower unemployed rates, you see a lot of underemployment, and that's showing up in decreased benefit levels. And those benefits have increasingly higher and higher deductibles. And as that occurs, that becomes, at least for the low-end service, a self-pay retail market.
Yep, it does.
And so, there's that type of opportunity as well. I'd like to go back to Lynn's comment about care coordination. The notion of care coordination from a policy perspective, has been really, talked about extensively, for probably 25 years, but certainly, with a high degree of focus for the last, 10 years. Organizations like NCQA, it's a national accrediting organization, has put a major push on primary care medical homes. You can now have a physician's office certified to be a medical home. CMS has provided lots of dollars for demonstration projects. And despite all of that emphasis, and many blue plans, many commercial insurance companies have made investments, made grants, changed their contracts to sort of put those types of programs out there. Despite all of that effort, there has not been anything which has shown up out of those demonstrations which shows that the cost curve changes in material ways.
And that's even very recent?
That's even very recent.
'Cause I've heard that we are actually making a dent. I think
Making a
we
dent in-
couldn't even really determine a few years back what the cost was in the dual eligible, because we didn't have systems that could communicate those numbers. But I think, I think the incentives are starting to get aligned. But let me just comment on the other question for a second. I think if the consumers have skin in the game, even in any of the disease states, I think you're going to see that they're probably going to get better value because they're going to seek that value. And whether they have to pay out of pocket, or they pay a higher premium, or they have more of a copay, or they're just smarter about their health. I guess that's where, since I'm in the health communications business, that's where we're going. Can we make individuals so much brighter about what they need that they will get a better value proposition out of the provider that they go to? So I'm a little more hopeful about the dual eligible about care coordination. I hope that at some point we're going to address the interoperability.
All I'm saying is that the evidence that I've seen, so far hasn't shown that it's changed the cost curves in material. It's had a very positive impact on quality, however you measure quality. And there's they keep on changing metrics that are being used, but you can show that if somebody's non-adherent on their diabetes treatment, their A1Cs are high, and you call them, okay, you can get them to take their insulin. If they're not taking their antihypertensives as they should be, they're on a 60-day renewal cycle as opposed to and you call them, you could see where, they tend to take their drugs more often or they tend to change their diets. It has not shown up, though, where you've seen, where you can track it back, where it has changed materially the trends, the cost trends. I still think it's hopeful, but I'm just saying thus far, and this is, I was talking to, there was a $26 million project in Rochester where targeted the highest risk populations, Medicare, Medicaid populations. They put nurses in doctors' offices, and they gave them registries to call. And I was talking to one of the medical directors, and at least, and they're in year 4 now, in the first 4 years, they have found, even though it was targeted to the patients that should have shown cost curve changes, they've not seen anything. And I asked him if there was any place in the country, and this guy said not that he knew of.
So you have a society that has expectations of exceptional interventional care to repair all their bad lifestyles, for instance. And one interesting thing I noticed that, the proliferation of the Da Vinci robot, the surgical robot, it's kind of leveled the playing field. Back 10 years ago, if you wanted a certain surgery done, you had to go to Johns Hopkins for this or Mayo Clinic for that. But you put the robot in the hands of a community hospital, urologist, or a general surgeon, and all of a sudden technology leveled the playing field. So you could go to New York City to the famous Hospital for Joint Services or Hospital for Special Diseases and get a surgery. But now you can go over to Community General over here on the hill and get the same quality of care with a surgeon that's been trained to use the robot. So here's where technology has kind of allowed more people to experience the higher quality of care. And so I think they get that expectation. So how are we going to manage those high expectations of the population and also reduce the cost, or at least keep it cost neutral?
You want to start? You're a device manufacturer.
Well, I love to study businesses, and I love to contrast the financial industry and the healthcare industry. In the financial industry, you can go online, you can know everything about your bank accounts and your investments and your portfolios and when you bought something or what it was, what it is now or what it's trending to. And now think about the parallels in healthcare. And the parallels in healthcare just aren't there. And so much of this is, there's plenty that's behavior driven. And it's begging for the need for good access to one's own personal health records. And it's mired somewhat in some regulatory challenges and then some other standards, well, what standards should we choose? But I honestly believe that if there were a day when someone could, go to their own secure, and by the way, most financial inquiries that we do online are secure. Everyone will always say, gee, you can't do that because it won't be secure. Well, goodness gracious, we're looking at our investment accounts online. We should be able to look at what our A1C is or what anything else is. And truthfully, I don't know what my last count was. I'd have to go to my doctor to get that. So having an electronic medical record standard, I think would be one of the biggest single things that could really move the needle for a large part of the population.
So I could remember having the discussion about barcode, right? And I think it was either your dad or Kevin Joe said that it wasn't until Walmart said, this is the barcode standard, that it became the barcode standard. And who in healthcare is going to be able to do that? Because I know the free market didn't work, right? We have to now pay our doctors $45,000.
Yeah, but these guys, I mean,
Right.
I honestly believe that it's going to be someone like Apple who's trying to.
BlackBerry.
Or,
They say they have the secure system.
yeah. But be able to have that type of data, because I think Apple is the version of.
So you think it's going to come
of
from
Walmart.
outside the healthcare industry?
A lot of innovations coming from outside.
I think so. Yes.
Yeah.
I think it'll come from the
I
IT
agree.
industry.
That's a different question.
So
Yeah,
your question, Bob, was, there's a demand for new technology to levelize, quality of care, across geographies. And you don't have to travel 3-4 hours to to get to the best, that you can get the best down the street. And I agree that there is going to be consumer demand for that, and there's hard evidence that that's already shown up. We also know that a lot of that technology is very expensive, and we also know that a lot of the technology, unless used a fair amount, doesn't generate the same outcomes of care. You don't want to be the first guy that the urologist is doing robotic surgery on, and you want to find out whether the guy has done 100 a year or whatever the minimum threshold is. And so you don't want there to be one in every doc office. I think that the interventions really fall into two categories. There's a regulatory intervention called health planning, and at least in New York State, you're seeing a rebirth of that. The health department has gotten a little tougher, at least on the high-cost technology, to say how many per region should be there. They also will sometimes look at technology assessment. Is it ready for market deployment yet or not? And I think that that will sort of continue down the track that it has, certificate of need types of laws. I think the more important one, which will be more ubiquitous, is that as these cost curves continue to go up, at some multiple of inflation or wages or whatever basis you care to use, you're going to see, and it won't be in every market, but in most markets, you're going to see competition between delivery systems. Delivery systems will integrate. If care coordination works, they'll pay for the nurses. They'll do it across payers. They'll take risk. There'll be capitation or episodic or some type of bonus if you beat a budget, some type of pay-per-performance. And just the way, Eric, you decide whether you're going to open up another line or not, these integrated systems will decide whether or not they're going to be an early adopter, whether they're going to put up a second line or not. And it won't be an outside force, won't be an insurance company or the government, but it'll be more integrated. And I actually think that's going to be very good because the physicians, the clinicians, will begin to balance the cost and quality issues and access issues and service issues. And I think we'll end up with a happier public as that occurs. Can I make a quick comment on the IT stuff, the HIT stuff? One of the hats that I wear beyond the University of Rochester is I'm chair of the New York eHealth Collaborative, which is the organization that, at least in a titular fashion, attempts, along with the state of New York, to coordinate all the regional health information organizations. The one here is called Hackney. And clearly the standards issue is significant and the security issue is significant, but they're working their way through those. Okay? The issues that really get in the way of us having all of our medical information on our smartphones have to do more with adoption. How do you get a doctor to use a medical record that will present to the patient in some friendly portal their A1C results or their cholesterol results? And actually, in this part of the state, we're doing remarkably well. If you go across upstate, we're doing very, very well. You go downstate, unless you are tethered to one of the academic medical centers, one of the big hospitals, you basically don't do it.
So with the meaningful use criteria, though,
that was not
meaningful use
sufficient.
Well, I mean, now that you have patient portals, that you have to demonstrate that you have a patient
But I'm
portal.
saying from an adoption perspective, you got some of the early adopters, you got up to maybe nationally 15, 20% adoption on doctor, not hospital, doctor-entered medical records, okay, and then it plateaued. And whether it'll grow from here, there's meaningful use incentives have dissipated. The issue, and then if you're on a system which doesn't talk to the hospital system or the regional system, you got to come up with another $5,000 or $10,000 to write the interface. And it's until we get ubiquitous adoption, okay, what you're looking for won't be there. And Apple and Google, and you have to get the guy who is ordering the test and who the test result is coming back to to be the one to give you that information. And it's scary because I don't know, the government's not going to come up with another incentive program.
I think the adoption, well, I don't have the exact number, but certainly the EHR adoption's a little bit higher, I think, than what you're talking about. The bigger issue, though, is that there isn't interoperability. So a lot of these systems are siloed. So even if your hospital is signed up or you've bought into, let's say, Practice Fusion, which is a advertising-based EHR, they're not able to work as functionally as they should, including communicating to the patient. But I think you're going to see more of a push now, again, because more of the providers are being told they won't be paid as much if they can't demonstrate that they're communicating with their patients. And that's either going to be through the portal or through some sort of mechanism that goes to the phone.
But I think to Eric's point, so if the consumer is very interested in diabetes and their hemoglobin A1C, there's probably 4 or 5 things they could achieve with a very simple app on a handheld, and they don't need the behemoth EMR. I mean, having experienced a recent installation of an EMR at our academic medical center, and I run the pathology lab, and we provide a lot of the data that goes in there. The EMR, for instance, wants nothing to do with our blood bank because blood products are regulated by the FDA, and they don't want anything to do with it. So we have to have a special information system just for our blood products. And then they've got their codes, and our laboratory information system's got its codes, and they don't meet. So we get the angry doctor that's doing that order calling us up and saying, I didn't order this test, or I did order this test, or why didn't this test go out to a specialty lab where we need it? So when you go to the IT people who are supposed to be bringing this seamless solution to our clinicians, they're overwhelmed. I mean, they're just trying to implement this IT thing. So I'm wondering if, I'm watching the medical students and the residents figure it out without the EMR. And they're doing it via text, and they're doing it via email, and they're figuring out ways to manage their patient very disruptively, like many of the innovations that occur in healthcare. They're kind of small, incremental, good enough, and then the next thing you know, everybody adopts it. And I saw that when the virus-based cervical cancer issue came out, and everybody was resistive of using it, but it was the consumer that said, you already have the pap smear, all you have to do is take those cells and put it in a liquid solution, and you can tell whether I have a certain virus that causes cervical cancer. The consumer kind of drove that, and I'm hoping that there's more excitement about consumers being innovative and pushing our big battleship of healthcare in the right direction.
I think the other place where the battleship will start moving is, management of payments. I mean, right now, the more care that's being delivered in most instances, the more everybody gets paid. So it's a kind of a weird incentive, albeit not totally unreasonable. Now, when you start saying, okay, well, for an episode of cardiovascular acts, hospital provider, you'll get $15,000, figure it out. Now there's a much larger incentive on the hospital to say, okay, well, okay, I got $15,000. Now, how do I make sure that I get really good quality care and deliver that for $10,000, $5,000? So I think, for entrepreneurs or technology providers, I think those places where, and that's already starting to happen. So then you can go to the hospital and say, hey, I can figure out a way for you to deliver that more cost effectively. It's much harder to do that in other areas. If you say, hey, we had an experience, and this was very instructive for me, is like, there is no capitation for implantable cardiac defibrillators in terms of if you get diagnosed into it. And we were working on a new technology that could say, hey, right now you need to implant 9 of these to save 1 person because the other 8 aren't given to the right person, but the system doesn't know that. So we're working on a technology that would say, hey, who's that 1 out of the 8 folks who would get that ICD? Yeah. But the problem with that is, and fortunately, the physicians that we're working with were honest enough about it. They say, hey, well, that's great. That's going to suck for us because we make a lot of money out of implanting those things. So I think as the system becomes more transparent, I'm like, okay, well, there is this cap. Okay, now how do we work on margin? I think more interesting technologies will get rolled out.
Yeah. I actually think as the health system integrate, as doctors, become employed by them, as they own pharmacies, as they own labs, as they own urgent care centers, and they become more Kaiser-like. Okay, all of the adoption, all the information, all the patient portals will emerge because that becomes a basis of competition.
Yeah.
There's a lot of consolidation.
You know, I just want to mention one
A good
thing.
example of one was that I heard recently was from Cleveland Clinic. So the number one diagnosis is low back pain in the country, and they analyzed all their patients, and they saw that everybody that came in, 30% right off the bat went to a spine specialist, and before you know it, they were getting surgery. And they had done a whole outcome analysis of all their low back pain patients, and they said, hold it, we want to save 30% of this money, to your point, because they can actually put that money maybe in their pocket if it moves towards away from fee-for-service and fee-for-outcome. And so they have changed their system entirely. Everyone comes in, everyone sees their primary care doc, everyone has to see a physical therapist for a period of time. Everyone has a mobile app that the physical therapist uses so they can see the exercises that they need to do. And at a certain point, yes, you can go to a spine specialist. They've cut their opioid use by X%, they've cut their costs already, and they're taking on these big ones. And so there's a lot of money to be saved when you add technology-enabled care,
Now,
to your point, patient type of...
How would they, out of curiosity, and you may not have the details, I think that's a great example because you pull out a lot of unnecessary costs. How were they able to justify it economically, as crazy as that sounds? Because now they're not
in the hospital.
because now they're not doing the spine surgery.
This is the dilemma. You know, it used to be heads in the bed, or what is it called? And now it's about keeping people out of the hospital.
Actually,
Hospitals are struggling with that.
I may be wrong, but if I'm wrong, I'm not wrong by a lot, okay? CMS came up with a program a couple of years ago called the Bundled Payments for Care Improvement Program. Okay, and there are about 40 episodes of care. Back pain is one of them. And I think Cleveland Clinic was an early adopter of that program. So there's a little bit of risk adjustment in the episodic payment they receive. But you know, they are then, and there's a triggering event defines the beginning of the episode, but my guess is that's the way they're working the economics of it.
And those are the
But there's a
really-
lot of pilots like that going on.
Yeah, well, this is,
Yeah.
there's I'm told that there's like almost half the hospitals in the country have signed up for at least one bundle payment
great.
demonstration.
Yeah. And I think those are the places where it's easiest to deploy new stuff because now everybody's economics are aligned in the same way. And now you can say, okay, we want better outcomes. We want to deliver it more cost effectively. And if we can do that, everybody wins.
Yep.
Yeah, it's interesting though because you have these highlights, these little wins that occur based on a disease. A colleague of mine in San Diego called them stunt science. But it was funny when the first couple of years I started with Welsh Allen, we went out to Kaiser, and I was very excited about a glaucoma detector we had. And I got in front of the chief medical officer of Kaiser. I said, this machine will detect glaucoma 5 years before traditional therapies or traditional diagnostics can. And it's really a degenerative disease of the nervous system. And he looked at me and he said, boy, you haven't been at the job very long because I don't want to detect it 5 years ahead of time. I'm anticipating these patients won't be in our system in 5 years.
Yeah,
So why do I want to
that's
get
the
it
episode.
early and get into it? I'd be interested in
Well, the whole system has been built around episodic care, and you don't have the people in your system long enough to make those long-term outcomes meaningful financially, and that's got to change. You know, that's where the you know, kind of owning the whole continuum of care and owning the patient for a very long time.
So does
is
it require an
essential.
overhaul? I mean, a big overhaul of the system, or is that pie in the sky thinking?
You know, it's,
Kaiser does it well.
I'm surprised that Kaiser has that much churn where they wouldn't be interested. I mean, that's just
Yeah.
a visceral reaction to,
Of all the places.
you know, because the satisfaction levels there are remarkably high. But let's assume that they did have that much churn. My guess is that over time, as delivery systems become more competitive with one another, you'll see something like durational pricing show up. You know, like you have on automobile insurance. If you stayed with the carrier for a certain period of time and you haven't had claims, they decrease your deductible or thing. And I could see some innovation like that emerging. I don't see that happening
Have you heard
quickly.
of Castlight? They do reference
do
pricing.
what?
Castlight, have you heard of that company?
Yes, yeah, yeah.
So that-
They sell consumer information. I think it's mostly a marketing company, notwithstanding how they present themselves.
Yes, but they're kind of pushing this idea of
Yeah.
reference pricing.
Yeah. Well, reference
and-
pricing is different than durational pricing. Okay. Reference pricing would
Right.
be, it's almost like an old indemnity product. You'll say, for, a heart transplant will pay $75,000, and here's a list of providers that will do it
That
for
will do it, right.
$75,000. If you want to go someplace else, you can.
I'm going to open it up to, there's some audience that want to ask a few questions.
So after that collective problem assessment, Eric, I feel like you ought to open the bar early.
Open the what part?
The bar early.
So if in this room we had an entrepreneur who was prepared to invest 5 years and an angel investor who had a spare $10 million, what would any of you suggest that they do with it to address the problem?
Well, I would say, ultimately, as we were, talking about earlier, like you take money, you've got a fiduciary responsibility to your investors. So you have to go to those places where you have the greatest opportunity and least battle. So as an entrepreneur, I never take on any of things of this scale because I think it's for societies to solve, not an individual entrepreneur to solve. So I think places which are out-of-pocket pay, dermatology, vision, dental stuff, those are great because you've got a direct customer, whether it's the dental practice or or a similar practice, and you've got a direct payer who's somebody who's paying out of pocket. Traditional economic capitalistic model, those are great. Innovation moves in those areas extremely rapidly, none of these insurance complexities. If you're doing something within the space that's more insurance payer oriented, I would go to those areas that we talked about where there's, you've got incentives that have been aligned in a way that everybody wins, which is, okay, there's an episode for which, Medicare, Medicaid will pay, $10,000. Okay, now it's really helpful for the hospital to implement a system where you can move the cost of delivering that from $6,000 to $3,000 and get better outcomes. Those are the kind of the things that I would look at. And ultimately, anything that you look at, figure out who's going to pay for it. And kind of going back to it is like, okay, clinical outcomes are good, but does the consumer pay for it, and do they actually want to pay for it? Does it make the economics better for the hospital and they'll pay for it, or who's the payer? So I think because it's such a huge component of the economy, there's significant pockets of opportunity, but you have to be very thoughtful of which ones you go after, because otherwise you could run aground because there's some complexities there.
I mean, I love the idea of starting with private pay for sure, absolute for sure. So if I'm an investor, if there are private pay models, absolutely number one. If it's general health, having something that fits into the future of a healthcare system, what we've really been hearing about, which is an integrated delivery network, it has to be able to fit into that. The idea of selling things that, making things and then selling them to physicians who use them to get paid more, those days are, sadly for me, they are gone. So, building devices that help systems take risk, manage lives, know that there are, for every 10 bodies out there, there's one that I'm going to have to be concerned about for this disease state and another one for this disease state. That's a very different world from the world we've lived in. So
I would say that, I agree with you, the cash and carry business is probably easier to work in than the payer business. But I think the big opportunity is health is ubiquitous. I mean, there are so many new companies and so many industries that are jumping into health. We now have Apple in health. We have companies we never thought would appear in health. And, the wearables industry is about $56 billion is, I think, the current estimate. So building on the mass consumerization of health, finding those aspects where people, those niches and those growing groups of people who are really interested in health and wellness is another area that I would spend some money in.
Which means you need to be able to price compare, and you sure can't do it today by calling your insurance company or your provider, because they can't tell you or they won't.
I think also, big picture though, if you want to look in general categories, if you look at whatever you want to call it, personalized medicine or predictive medicine, if you look at things that are predictive, things that are preventive, things that are personalized, that is revolutionizing medicine right now. We are renaming diseases based upon their genetic profile. And the therapies now are becoming precision based on appropriate diagnostics. So if you get the diagnosis right and you're precise with the therapy, you have great outcomes. Now, some of them are pretty costly, but I think the costs are going to be coming down. I was working with a company called Foundation Medicine in Boston, and I told a couple of my friends, I think this is a hot company, and a week later, Roche bought $1.6 billion worth of their stock. I'm seeing it now in the hospital. We are renaming diseases based on their gene profile. We're doing microbiology tests based on genetics. So I think that would be a place that you might want to consider, things that are better on diagnostic side.
I agree with, self-pay versus third-party pay as a screening criteria, but that's going to limit the market. I mean, that's not, you can make money there, but it's not the bulk of the market. I would say the categories fit into, engagement, consumer engagement, which the wearables would fit in, which, compliance, adherence, assisting devices would fit in. And then on the other side would be what I'll call unwarranted clinical variation.
I didn't hear you, Mark.
Unwarranted clinical variation. And it's really trying, where there is waste, is there some intervention that you can make to reduce the waste? And sometimes it's a different delivery system, sometimes it's clinical decision support, the sorts of things you're talking about with the genome.
I work with a company called Athena. They're a cloud-based electronic medical record company. And I think Jonathan Bush has a really interesting strategy. He calls it More Disruption, Please. And so they've built a really outstanding EHR system. It's cloud-based. There's only one other cloud-based. Their model is based on helping providers deliver medicine better. So they get paid when the doctors get paid. That's how they make their revenue. But they don't, and they're also incredibly good at interoperability. So they're asking, entrepreneurs to come their way with their inventions that they can, in fact, put on their EHR, whether it's a better, patient entry system or an adherence support system, but things they don't want to build. And I think in the EHR space, there's 420 EHRs in this country, and I think each one has less than 10% of the population or something, something similar to that. So you're going to see a lot of consolidation there and a lot of eagerness in some cases to build a better system because the biggest ones are actually not as flexible as some of the newer ones. So that might be small potatoes. I kind of agree with you, but these are incremental advantages that people will buy if there are some entrepreneurs out in the audience.
I just add on, so the EHR, the electronic health record that hospitals use, really important, great opportunities. I agree there will probably be consolidation. And there are 400 of them today.
Right.
Now think of how many device makers or
Right.
lab companies or blood analysis or ECGs or blood pressure devices are out there. And each one of these, for years, this country made ECGs, which look like boxes, which spit out pieces of paper, 8.5 by 11 pieces of paper with a bunch of wiggly lines on it that he can read. What EMR companies did for years is they then took that digital information that was put onto a piece of paper
Faxed it.
and scanned it into a freaking computer, which is the dumbest thing in the world. You have digital information, go to paper, to go back to digital. The opportunity to integrate devices into electronic medical records is a tremendous opportunity.
Yep.
The further opportunity, and the one that just gets me so excited, and is taking that data and being able to do something incremental with it. If you have 10 years worth of your ECG data, okay, on sheets of paper, you can't really do that much. I guess you could look at it like this, and a good cardiologist might be able to tell something. But if you had that all digitally, you could very easily have algorithms that analyze the change in the waveform over time and say, your ST elevation is changing a little bit over the last 10, 12, 15 years. You are more at risk. So there's incremental clinical information in the digital data. And that would be another area that if I was in investor's shoes, I'd look at as a
I
wonderful
was
opportunity.
at Watson World last week, IBM Watson.
IBM.
And that's, that's really the future of medicine, where Watson will be taught all of that and swallow up all that information and make the kind of predictions and advise providers how to track, and people how to practice, how to treat themselves better. So that's another area that there might be opportunities.
We have another question, yeah.
So thank you.
You're welcome.
So there's been a lot of discussion about the need for an integrated delivery system in the medical segment of the healthcare industry. How do you take those same innovations and bring them about to the non-medical or the home care sectors where kind of the initial primary care really starts?
Who wants to start with that one?
That's where the action is, right?
Yeah, I think the hospital as we know it today won't exist in another generation. That you'll still have hospitals, and there'll still be surgery there, or if somebody's in congestive heart failure, they'll end up there. But more and more care will be delivered, at home or in ambulatory care centers, and the whole telemonitoring. You guys have made huge investments in that area. I think is where it's headed, and that'll be, again, engagement types of tools. At the risk of an advertisement, you won't throw me out, Somac, will you? No, Somac. I was going to talk about PharmAdva. Okay, so one of the investments that I'm involved with is potentially a hub, a telemonitoring. Consumer engagement hub. If you look at prescription drugs today, about half prescriptions are not taken as they're supposed to be taken.
Yeah.
And it's an unintentional non-adherence. It's not that somebody says, the pill makes me sick, I'm not going to take it. You simply forget. Okay, I look like that patient. Okay, I forget all the time to take the meds I'm supposed to take. Now, sometimes that doesn't matter. I'm fundamentally healthy. I get indigestion if I don't take my Prilosec in the morning, something like that. But if you're an HIV patient, if you're on the Hep C drugs, if you have a handful of comorbidities, not taking the drugs virtually guarantees either the cure won't work or a trip to the ED. Mm-hmm. So without going through all the details, this hub that we've created prompts the patient per program to take the meds when they're supposed to take them. Okay? If they don't take them, there's a dispatch function which calls up their caregiver or their insurance company or their pharmacy to say, hey, they didn't take the drugs. Okay? We're in prototype, about to go into production. Okay? If it works, that becomes next to the Keurig, a device that sits on the counter, and with that you can pick up blood pressure, glucose monitoring, weight, fluid retention. There's all sorts of things. It becomes a home appliance that you use to deal with that non-adherent patient.
Yeah, ultimately there will be devices that would help any individual become more of an allied health professional. So the combination of education, in-the-minute recommendations, adherence reminders, all of that, again, if you add a little Watson to it, probably even smarter, but those are the kinds of tools that don't exist right now for the kind of home care that we really need. There really should be a platform out there with education, community, and commerce all timed to a care plan over time. And I think these things will be built. They're just not built yet.
I would anticipate the home care agencies becoming part of these health systems. I would anticipate the primary care doc having care plans.
Right.
Okay, and this would become a tool. The home care agencies become the distribution channel for these types of engagement assist devices.
Excuse me, we have time for one more short question. As engaged as this is, we do have a schedule to follow.
Yes. Wait, you want to wait till you get the mic.
As a local physician in town, nearby, I've been practicing in Lafayette for about 15 years, and then in Syracuse. I'm part of this family care medical group, which Eric...
I didn't hear your question, I'm sorry.
Yeah, my question is that, as a family physician, my biggest problem is documentation. I spend time seeing the patient for 10 minutes and then going on the computer and typing this notes for about 10, 15 minutes. So I think a place where innovation should occur is during documentation. If there is something like, instead of EMR, if we have VMR, video medical recording, where we walk in and we talk about it, and somewhere somebody's typing your whole consultation and then presents it as a note would be a good thing for somebody to do.
Yeah.
I don't know, what do you?
Yeah, paying you for your secretarial work at doctor hourly rates, it doesn't make sense.
Yep.
Okay.
That's the old.
The solutions are coming slowly. The non-elegant solution are scribes, and you're seeing more and more of that. You're seeing voice recognition, more and more of that. You're seeing macros, which probably work in the wrong direction because then you get information overload. I'll back up what you said. At the University of Rochester, when they put Epic in for orthopedics, there was an 8% drop in productivity.
Thank you all very much. It was an amazing panel.